Hey, how are you doing? So today we'll continue with the cardiovascular system, and today's topic will be origin and spread of cardiac impulse. So let's get started. So we'll divide this topic into two parts. First, we'll discuss about the origin, and then we'll talk about the spread of the cardiac impulse throughout the heart. So before we begin, I just want to give you a very brief point about the structure of heart. From this is the heart, anatomically not very perfect, but for understanding this is good. So from outside inwards, if we go from outside inwards, the heart structure can be divided into three layers. The outermost layer is the epicardium, the middle layer is the myocardium. This consists of the cardiac muscle cells, right? Epicardium, myocardium, and the innermost layer is the endocardium. This is the endocardium. This is the epicardium. This is the myocardium, and innermost layer is the endocardium. And this right here is the cavity of your atrial ventricles, right? So from outside moving inwards, the layers are epicardium, myocardium, and endocardium, right? So this is the basic structure of the heart. As you can see here, I've labeled right atrium, right ventricle, and left ventricle. So first we'll talk about the conducting system of the heart, how it is located and where the structures are present. So as we all know from our 12th standard knowledge, that the conducting system of the heart is made up of basically the SA node, the AV node, the bundle of His, the bundle branches, and the Purkinje fibers. I'll just quickly brief through it again, right? So this is the starting point. This is the SA node. The SA node is known as the pacemaker of the heart. Why and how? We'll come to that in a while, right? So this is the SA node, the sinoatrial node. It is located in the upper part of the right wall of the right atrium, near the opening of superior vena cava, right? See, this is the right wall of the right atrium. This is the right atrium. This is the right wall. In the right wall, in its upper part, near opening of superior vena cava. This is the superior vena cava. So this is the location of the SA node. And the SA node's measurement is 15 by 2 by 1. 15 millimeter is length, 2 millimeter is the thickness, and 1 millimeter is the width, right? So this is the SA node, right? Moving on, the impulse starts here in the SA node. Therefore, it is known as the pacemaker. Impulse starting here spreads from the right atrium to the left atrium, and also from SA to the AV node. Now remember, impulse starts in the atria and moves to the ventricles. There's only one channel, only one gate for the impulses normally to move from the atria to the ventricles, and that is via the AV node. This green structure is the AV node. So under normal conditions, AV node is the only way through which impulses that originate from the SA node pass from the atria to the ventricles. Okay, so impulse has to travel from SA node to AV node. In the meantime, impulse also travels from the right atrium to the left atrium. Okay, so there are certain fibers, certain conducting fibers which conduct the impulse from the right atrium to the left atrium. As you can see, this bundle here, this is known as the interatrial fibers or Bachmann's bundle. BACHMAN, Bachmann's bundle. Okay, so this is known as interatrial fibers or Bachmann's bundle, interatrial fibers, right? So SA node to AV node, the impulse has to go. How will it go? Very simple. The fibers connecting the two nodes, the SA node and the AV node, are known as internodal fibers, right? Inter means between the two nodes, internodal fibers are present. Now these fibers are arranged in three groups. Anterior, this right here is the anterior one, this is the middle one, and this is the posterior one. Okay, so anterior one I have labeled it with green. The anterior internodal fiber, this one, is also known as Bachmann's bundle. Now remember, Bachmann's bundle is here also, and the interatrial fibers are also known as Bachmann's bundle. Okay, this is Bachmann's bundle, this is Bachmann's fiber or the anterior internodal fiber. The middle one here, as you can see, this part is the middle one. This is the middle internodal fibers are also known as Wenckebach's fibers, right? Wenckebach's. Anterior, middle, and the third will obviously be the posterior. Posterior is also known as, this is the posterior Thorel, fibers of Thorel, right? So anterior, middle, posterior, Bachmann, Wenckebach, and Thorel. So these are the three different names for the internodal fibers. So impulse starts in the SA node, passes through the interatrial fibers towards the left atrium, internodal fibers reaches the AV node. Now this is the detailed structure of the AV node, how the main structures are. So this, as you can see, is the anterior internodal pathway of Bachmann. This is the middle one of Wenckebach, and this right here is the posterior internodal pathway of Thorl. So if you notice here, they do not directly end. This is the AV node. So fibers are coming from the SA node. So from the SA node, when the fibers come, they do not directly end on the AV node. Between the end or termination of these three fibers, imagine these are the three fibers that are coming, and this is the AV node. So between the termination of these three fibers and the AV node, there are special fibers, right? There are special fibers which connect the ends of these three internodal pathways with the AV node, and these fibers are known as transitional fibers, right? Transitional fibers or transition fibers, these are known as. Okay. So transitional fibers connect the three internodal pathways to the AV node. Now, like I said, AV node is the only pathway normally through which the impulses pass from the atria to the ventricles. Now, before we actually see what this is, just come here for one moment to know the exact location of the AV node. This, as you can see, is the interatrial septum. The right and the left atria are separated by a septum, right? So this is the interatrial septum. On the lower part of the interatrial septum, on its right side, if you get this right in your mind, you will know that this is the right side and this is the left side, and the heart is directed slightly towards the left, right? This is the apex of the heart directed towards the left. So this is the right side. So as you can see in the lower part, on the right side of the interatrial septum is present the AV node. Okay, so AV node is here. But if you look carefully here, you can see this is the fibrous ring. Now the basic structure of the heart is like this. This is the atria, okay, and these are the ventricles, right? This is the atria, these are the ventricles. Now they are separated by a fibrous tissue ring. There is a ring of fibrous tissue, and this ring consists of your tricuspid valves on the right side and the bicuspid valves with the mitral valves on the left side. So there is a ring of fibrous tissue, as you can see here. So above the fibrous tissue there is atria, and below the fibrous tissue there are ventricles, right? So here probably somewhere will be the interatrial septum, because the AV node lies to the right of interatrial septum. Okay, so this is the fibrous tissue. Now fibrous tissue is an insulator. It does not allow the impulses to pass through them from the atria to the ventricles. Therefore, this is the only reason why under normal conditions, AV node is the only channel through which the impulses pass, because the fibrous tissues are insulators. They do not allow the impulses to pass, right? So this is the AV node. Now AV node, it passes or it pierces through this fibrous tissue and moves distally. Now what does distally means? Away. Here we are considering the reference point to be SA node. Since the impulse is starting from the SA node and moving away, we say the impulse is going distally. Distal means away and proximal means near or coming towards a reference point, any reference point. Here the reference point is SA node. So this is the distal part or the away or the further part of the AV node, right? Distal part of AV node, and we all know distal part of the AV node slightly extends downwards as the bundle of His, right? And the bundle of His soon divides into right and left branches. The bundle of His soon divides into right and left bundle branches. Coming back here, these are the right and left bundle branches. They move and further divide into Purkinje fibers. This is all we know, right? So this is the basic anatomy, the basic layout of the conducting system of the heart. Now another very small point but significant point is that these Purkinje fibers, they are subendocardial. Like I said, the layer of the heart, first outermost is epicardium. The middle layer, this is a thick muscular layer known as myocardium, and inside the innermost layer is the endocardium. These Purkinje fibers are present here. Subendocardial, sub means below. Just below the endocardium are present these Purkinje fibers, right? So this is the basic layout of the heart, and this is how the impulse once generated, this is how it spreads, right? This is the path it follows normally, starting from the SA node, interatrial fibers, internodal fibers, AV node, the bundle of His, the right and left bundle branches, and the Purkinje fibers. Now I introduced SA node as the pacemaker. What do you mean by pacemaker? Pacemaker means the point or the system, or from the point from where the impulse originates, right? The part which sets the pace. Now what do you mean by pace? Pace means heart rate and heart rhythm, right? Heart rate and heart rhythm, that is the whole meaning of pace. So pacemaker is SA node because the heart beats at the rate at which SA node fires. If SA node fires once, there is one heartbeat. If SA node fires again, there is a second heartbeat. If SA node fires third time, and so on, right? So the pace is made in the SA node, therefore SA node is known as the pacemaker. Now, why does SA node act as pacemaker? Does any other part of the conducting system have this ability to generate the rhythm, to generate the impulses? Yes. This ability is known as autorhythmicity. Auto means self and rhythmicity means capacity or ability to maintain or to generate a rhythm. Now keep in mind, SA node is not the only tissue that has been blessed with this capacity. Okay, SA node or any other part, the AV node or the Purkinje system, any part of the conducting system is capable of generating a rhythm and maintaining it. So the question comes here, why is the SA node considered as the pacemaker? Why not others? Why does the heart beat only according to the rhythm generated in the SA node? Why doesn't the heart beat according to the AV node or according to the Purkinje fibers? The reason is very simple. The reason is because SA node generates impulse at a higher rate or faster compared to AV node and Purkinje fibers. Now, the rate of generation of impulses in the SA node is about 90 to 120 beats per minute. This is for SA node is equal to 90 to 20 beats per minute. Okay, and this is known as the intrinsic heart rate. Okay, but now you might ask that SA node generates this much rhythm, but we say that the normal heart rate is 60 to 90. So if SA node is generating this much rhythm, why doesn't the heart beat at this rate? The answer is there is innervation of a very important nerve in the body called vagus nerve. Okay, vagus nerve. Now how exactly vagus acts and how exactly vagus reduces this intrinsic heart rate, we'll come to that later. For now, just remember that the intrinsic heart rate or the rate at which SA node produces impulses is 90 to 120 beats per minute, and that is reduced to the normal limits by the activity of vagus. Okay, the rate of rhythm generation or cardiac impulse generation in AV node, it is about 40 to 60 beats per minute. Okay, and in the Purkinje fibers, it is about 15 to 40 beats per minute. So as you can see, SA node is the fastest. Therefore, heart follows the rhythm and the rate generated by the SA node and not by the AV node and Purkinje fibers. Yes, AV node and Purkinje fibers, in fact any other part of the heart, is capable of generating a rhythm, but the heart does not follow its rhythm under normal conditions. Okay, therefore this is known as the pacemaker. The one that sets the pace is the SA node under normal conditions. Now why am I stressing on the word normal conditions? This is because there are certain conditions, certain diseases in which the SA node fails or there is blockage of this conducting system here. Okay, so since there is blockage of this conducting system here, SA node impulses cannot spread to the rest of the heart. Therefore, the heart will not beat at the rate generated by SA node. So the AV node has to take up the activity. Now the AV node will generate the rhythm at the rate of 40 to 60 beats per minute and heart will follow its rhythm. This is known as ectopic pacemaker. This is known as ectopic. Now remember, ectopic means any other pacemaker besides the SA node, and this is seen only in disease states. Normally pacemaker is SA node. Any other pacemaker in any other part of the heart, not necessarily AV node, any other part of the heart is known as ectopic pacemaker, and that is abnormal. Okay, so this is the basic of the spread of the cardiac impulse. We'll go into detail now about how the SA node generates the rhythm and what exactly is the autorhythmicity property and how exactly vagus plays a role in determining the normal heart rate. So till now we have seen how the cardiac impulse originates from the SA node, also known as the pacemaker, and it spreads through the various fibers forming the conducting system of the heart. Now let's look into detail the pacemaker activity of the SA node. Okay, so SA node, imagine this is the SA node. Okay, it is made up of numerous rounded small cells, right? Now these cells are known as P cells, P for pacemaker. Okay, P cells. Now SA node produces or generates the cardiac impulses. It means that it forms action potentials, right? We've discussed in detail how action potential is formed. Okay, so the difference between normal action potential and the action potential in SA node is that SA node does not require an external stimulus. It has the property of autorhythmicity. Now why and how does this autorhythmicity work? Now these P cells are present in the SA node. So let's consider this is the cell membrane of a P cell, or for understanding purposes of the SA node. Okay, this is a cell membrane. Now we know that there is resting membrane potential normally present across the cell membrane at rest. In the normal large myelinated nerve fibers, or in the skeletal muscle, or in the cardiac muscle, the normal value of resting membrane potential is about -85 to -90 millivolt. Now why it is negative and all that we have discussed in the resting membrane potential. But here in SA node, there are two specific properties, two specific differences in the resting membrane potential. First is the normal value of the resting membrane potential in the SA nodal fibers is about -55 to -60 millivolts. It is -55 to -60 millivolts. And the second part, the second characteristic feature of the resting membrane potential of SA node is that the resting membrane potential here is unsteady, it is unstable. Now remember, in all other tissues of the body, the resting membrane potential is fixed. It remains at a value of -85 or -90 unless it is stimulated by an external stimulus, right? But here it is not the case. Here the resting membrane potential is unsteady. So we say the second part here is unsteady resting membrane potential. So these two are the differences or the characteristic features of resting membrane potential in SA node. Okay, so now we've seen this. Now let me explain to you how actually autorhythmicity works and why this is known as the pacemaker. So let me just get this out of the way so that I can explain it to you more clearly. Okay, so this, as you can see here, this is how the action potential curve of SA node appears. Now this is -55 to -60 millivolts was the resting membrane potential. So this level that you can see, this level is resting membrane potential. It is RMP. Okay, this is the resting membrane potential here, right here, -60 millivolts. Okay, the cell is at resting membrane potential, it is at rest. Now there is no requirement of external stimulus. Okay, remember here, what happens is that the potential, the membrane potential gradually rises. There is slow increase. The resting membrane potential slowly moves towards the positive side. Okay, this is known as slow depolarization. So we say that the resting membrane potential shows a slow depolarization. Why do we call it depolarization? Because we know from the action potential video that this positive part of an action potential is known as depolarization, right? So it is moving towards the positive part. So we say that it shows a slow depolarization. Now why does this happen? Look here, I'm going to draw this here. This is the slow depolarization and this is the next one. Now this is the threshold, right? And this is the resting membrane potential. Let me show you in a different color. so that you understand, this is the resting membrane potential, okay, and this is the threshold potential. We know that action potential starts only after the threshold potential has been reached, okay. So this is the resting membrane potential. Now what happens is that the plasma membrane or the membrane of the fibers of the SA node, they are leaky to sodium. Now we know sodium is the main cation of extracellular fluid. So sodium is present here outside the cell membrane. Sodium slowly moves in. So since sodium slowly moves in, the potential rises towards the positive value. So there is a slow rise. But the point to be noted here is that the influx of sodium or the leakiness of the sodium contributes only to only to this part of the slow depolarization, okay. So only this part is due to sodium. So what is the remaining part due to, and what is the action potential due to? Okay, so the sodium leaks in, and as soon as a particular level is reached, not threshold, a particular level is reached, after that T types of calcium channel open. What calcium channels? T calcium channels, that means transient calcium channels open, and they cause this further increase the potential. So this is known as slow depolarization, or this is also known as, this entire thing is known as pre-potential or pacemaker potential. Pre means because before the actual action potential starts, there is small potential that's been developed. So it is known as pre-potential or pacemaker potential, okay. So it is mainly due to sodium and calcium influx. So calcium also moves in via specific channels known as T calcium channels or transient calcium channels, okay. So this contributes to the pre-potential or pacemaker potential. Now as soon as a threshold is reached, there is large depolarization, okay. Now another interesting point here is that this depolarization is not due to sodium. Normally in all other tissues of the body, large influx of sodium causes depolarization, but here in the SA node there is no influx of sodium. There is in fact influx of calcium which causes depolarization, okay. And as soon as a threshold is reached, another type of calcium channels known as L calcium channels open. Remember, first sodium channels are leaky. Sodium leaks in, opens at T type of calcium channels. As soon as threshold is reached, L type of calcium channels open. L means long lasting. Long lasting calcium channels open. There is large influx of calcium and there is strong depolarization here. Okay, till this point. At this point, the calcium channels close and the potassium channels open. Okay, what channels open? The potassium channels open, and as we already know, it leads to repolarization. Okay, there's repolarization. It reaches the resting membrane potential. Again, the membrane being leaky, there is pre-potential or pacemaker potential. As soon as it reaches the threshold, there is action potential. Initial part of the pacemaker potential is due to sodium leakiness. The later part of potential or the pacemaker potential is due to T type of calcium channels opening, and the action potential depolarization is due to L type of calcium channels that open, and repolarization obviously due to closure of L type of calcium channels and opening of potassium channels. So this is the main reason why there is autorhythmicity. You see, the membrane is leaky. It does not require an external stimulus. It being leaky, sodium comes in every time the resting membrane potential is reached. Every time the resting membrane potential is reached, sodium moves in and there is slow depolarization. Okay? So this is the basis of development of autorhythmicity in the SA node. Now I've already told you why SA node is the pacemaker, because the rate of generation of impulse is the maximum. I've also told you that the intrinsic heart rate or the normal rate at which the SA node generates the impulses is 90 to 120 beats per minute, but the heart rate is not 90 to 120. In fact, it is between 60 to 90. Why? I told you it is because due to action of vagus. Now let's see here. In these two graphs, we'll discuss the action of vagus and sympathetics. Now you know heart has nervous innervation as well. Okay? So nervous innervation of the heart is divided into sympathetic and parasympathetic. Okay? So the parasympathetic nerve supply is mainly by vagus, And the sympathetic nerve supply is mainly by the stellate ganglion. It is mainly by stellate ganglion. Now what does parasympathetic do? Parasympathetic reduces the heart rate and reduces the force of contraction. Sympathetic increases the heart rate and increases the force of contraction. Before we go into detail how it's done, I just want you to note that this is the heart, right? This is the heart. Here we have the SA node. Here we have the AV node. The SA node is innervated by right vagus. It is innervated by right vagus, and the AV node is mainly innervated by left vagus. Just keep this in mind, okay? SA node is innervated by right vagus and AV node is innervated by left vagus. Okay, let's see what vagus does. So let's come here. Just look at these two action potentials, as you can see, okay? 1 and 2. Okay, so these are normal action potentials like we've seen here, right? These are normal SA node action potentials. Point A is where we have stimulated vagus. So vagus gets activated. Till here, till initial part, there was no vagus activity. Okay, point A is point of vagus stimulation. So what happens, you can see, is that the action potential duration was this much. Now the difference between duration and action potential has increased. This means the number of action potentials produced per minute has reduced. This means the heart rate has reduced. Okay, so why does this occur? Because vagus, it leads to opening or stimulation of potassium channels. It increases the permeability of potassium in the SA nodal fibers. So if the permeability of potassium increases, we know it causes depolarization, repolarization and hyperpolarization. So if the membrane is hyperpolarized, it is difficult to be stimulated. If it is difficult to be stimulated, that means that action potentials are difficult to be produced, which in turn means, of course, the cardiac impulses are difficult to be produced, right? So rate of generation of cardiac impulses reduces because vagus releases acetylcholine, and acetylcholine increases the potassium permeability of the SA nodal fibers. So there we can see the rate was this, different time difference between two action potentials is this. Now time difference has increased because vagus has released acetylcholine and that has increased the potassium permeability. Coming to the sympathetic innervation, what does sympathetic stimulation do? Exactly the opposite of parasympathetic. Increases the heart rate and increases force of contraction. As you can see here, the first two graphs again are normal activity of SA node. Point B is the point of stimulation of sympathetic supply of the heart. And as you can see here, the time interval between two adjacent action potentials has reduced. If the time interval reduces, this means more number of action potentials in a minute and more is the heart rate. Now how does this occur? Sympathetic, okay? Sympathetics basically release norepinephrine and epinephrine, but majorly norepinephrine. This norepinephrine acts on beta 1 receptors in the heart. Acts on beta 1 receptors in the heart, and activation of beta 1 receptors leads to increased permeability of sodium and calcium. Now we've seen here the entire story that the SA node activity is basically dependent on these two ions. So if these two ions have increased in their influx, the amount of these ions entering the SA node has increased, obviously the rate of generation of impulse in the SA node will increase. And calcium, as we all know, as we have all seen in the properties of cardiac muscle, how important calcium is in contraction of the cardiac muscle. Since there is more calcium, more is the force of contraction, right? So this is the activity of the nervous innervation of the heart, the parasympathetic and the sympathetic. As we see here, parasympathetic is by vagus and vagus reduces the heart rate. Therefore, under normal conditions, due to the normal activity of vagus, the intrinsic heart rate of SA node is 120. So it is reduced to the normal of 60 to 90 because of the action of vagus. Therefore, we say that the normal heart rate is not this, but it is this. Get it? SA node produces impulse at this rate, but vagus acts, reduces the heart rate to this level, and this is the normal heart rate. Okay? So this is all about the origin of the cardiac impulse. Now we'll see the spread of the cardiac impulse in the heart. So now let's see the spread of the cardiac impulse that has already originated or generated in the SA node. Now if you notice here, the impulse spreads from the SA node via the interatrial fibers to reach the left atrium, right? It travels from the right atrium to the left atrium. So both these atria get depolarized simultaneously and they contract simultaneously, right? Now remember, depolarization is an electrical event. The action potential when it spikes up, that's depolarization. Depolarization is followed by contraction. Contraction is a mechanical event. Okay. So the impulse travels from the right atrium to the left atrium. Now these were known as the interatrial bundle or the Bachmann's bundle. The conduction velocity in the Bachmann's bundle is about 1 meter per second. Okay, but it is not necessary that the impulses pass only through these fibers. The impulses pass via the atrial musculature as well. Okay, so the velocity of atrial musculature is about 0.3 meters per second. So as you can see, the impulses passing through the atrial muscles are slower compared to the impulses passing through the interatrial conductive fibers. Okay, moving on. So impulses generated in the SA node have gone through the interatrial fibers to the opposite or the left atrium. Now coming to the AV node, we have seen that between the two nodes there are three internodal bundles of fibers, anterior, middle and posterior. So these reach the AV node. From SA node to AV node, they travel through these fibers and the time duration is 0.03 seconds. This means after 0.03 seconds they reach the AV node. Now imagine this is the 0 mark. Here is where the impulse is originated. So after 0.03 seconds it reaches the AV node, right? These are the timings for the atria. Now depends, if the impulse is coming via the interatrial fibers, it reaches in about 0.06 seconds faster. But if it's coming via the atrial musculature, it takes about 0.07 seconds. And the further parts of the atria, since the distance is more, the time required is slightly more, about 0.09 seconds. Now these times are not really important, but if you can remember them, well and good. But here, this is a very important concept. Please pay attention. So till the AV node, we have seen a delay of about 0.03 seconds. This is because the impulses pass through these three internodal fibers. Now what happens is that they reach the AV node. At the AV node, there is a delay of about 0.13 seconds. And it is because of this delay, when the impulse comes in the bundle of His, the time is 0.016 seconds since it has been generated. Therefore, this means that when it reaches the bundle of His, it has a total of 0.16 seconds of delay. Now, out of this, 0.03 has already been discussed. It is in the internodal fibers. So 0.13 seconds delay occurs in the AV node. Now why does this delay occur in the AV node? This is very important. The first and the most important reason is that the number of gap junctions in the AV node are very less. Now more the number of gap junctions are basically gaps, there are channels. So obviously more the number of gaps, more rapidly the impulses will pass. Since there are less number of gap junctions, therefore the impulse velocity is reduced. Therefore there is a delay, time has increased. This is one reason. The second reason is that, as we have seen, that these are three internodal fibers. They end on the AV node via these special fibers known as transitional fibers. Now the conduction velocity in these transitional fibers is very less. It is about 0.03 seconds. Sorry, 0.03 meters per second. Right, that's velocity, right? So it is 0.03 meters per second in these transitional fibers, which is very slow. So this also causes delay. The third point is, the third reason for the AV nodal delay is that the resting membrane potential of the AV nodal fibers is much more negative. It is more negative than others. Since it is more negative, more time will be taken for it to go or to move towards a positive and cause depolarization, right? It is more negative, so more time will be required for it to come towards the positive side. So therefore, Another cause of this increased delay at the AV node is this. The fourth cause is that the conduction velocity in the AV nodal fibers itself is very slow. So the velocity in AV node is very less. So this causes a further delay. So these are the 4 reasons why there is a delay of about 0.13 seconds in the AV node. Now keep in mind, it is said that in the actual AV node there is a delay of 0.09 seconds. Okay, there is a delay of 0.09 seconds in the actual AV node, but when the AV node continues as the bundle of His, here in the bundle of His there is a delay of further delay of 0.04 seconds. So here, this is how the total of 0.13 seconds come, right? In the actual AV node there is a delay of 0.09 seconds, but in the initial part of the bundle of His there is a delay of 0.04 seconds, so that when the impulse comes out, before it divides into these branches, it has a delay of 0.16 seconds, 0.13 because of AV node and bundle of His, and 0.03 because of the internodal fibers, right? This is very important for you to note. And after that, it is really simple. 0.1 seconds it reaches on either side of the interventricular septum, that is in the right and left bundle branches. Then 0.18 seconds, 0.19 seconds it reaches till the terminal parts of the Purkinje fibers. 0.20 second it reaches the apex of the heart. 0.21 second it reaches the sides, and 0.22 seconds it reaches the uppermost and the posteriormost and the outermost part of the ventricles near the base, right? So this is the time duration taken for the spread of cardiac impulse. Okay, so we've seen the 2 conduction velocities here. Now just for your information, that in the ventricular musculature also, the conduction velocity is about 0.3 meters per second. It is about 0.3 meters per second, and in this Purkinje fibers, the conduction velocity is the maximum. It is about 1.5 to 4 meters per second. Okay, it is about 1.5 to 4 meters per second. So the velocity, conduction velocity of the impulse is maximum in the Purkinje fibers. Okay, so this is the spread of impulse. Now another important point that I think you should know is that we've already discussed the musculature or the actual structure of the heart. That is, this is the epicardium, the outermost. The middle layer is the myocardium, that is the cardiac muscle, and the innermost layer is the endocardium. That's right. Now we know that the Purkinje fibers are subendocardial. They lie just beneath the endocardium. These are the Purkinje fibers. The impulses are coming within these Purkinje fibers. So first they spread towards the endocardium. They also move outwards towards the myocardium and the epicardium. But they do not move directly like this. No, they do not move directly outwards. Instead they spiral outwards. Get it? They spiral outwards. They move in a spiral fashion outwards towards the epicardium, right? So this is one point. This is one of the characteristics, or you can say one of the features of how the cardiac impulse is conducted throughout the heart. Okay, so this basically covers all your concepts regarding origin and spread of cardiac impulse. Now let me tell you something really interesting. We'll basically discuss 2 clinical conditions. Okay, now these have a very fancy name, but they are really simple. Okay, so the first one we'll consider, let me get this out of the way. Okay, so the first one that we consider is WPW syndrome. WPW syndrome. WPW stands for Wolff-Parkinson-White syndrome. It is Wolff-Parkinson-White syndrome. Now what happens here? Please pay attention carefully. Now we've already discussed that under normal conditions, AV node is the only channel through which the impulses pass from the atria to the ventricles. But in Wolff-Parkinson-White syndrome, what happens is that AV node is there, but there is another connection between the atria and the ventricles. So what happens is that the impulse, instead of passing through the AV node, or rather along with the passage through AV node, it also passes through this extra connective channel. Now why is this harmful? Why does this lead to a syndrome? This is because AV node, as we have seen, has a delay of 0.13 seconds. That delay is necessary because the impulses must reach the ventricles a little later than the atria, so that the atria contract first and then the ventricles contract, right? The impulses will cause depolarization, which is electrical, will lead to mechanical contraction. Atria need to contract first and then the ventricles need to contract, right? But what happens in Wolff-Parkinson, that this extra bundle, this extra connection here, this has no delay. It has no delay. So by the time impulse passes through the AV node and reaches here, it has already passed through this pathway extra and has been spread throughout the ventricles, right? So this is Wolff-Parkinson-White syndrome. This is dangerous. Under normal resting conditions, a patient usually has no symptoms, but when the heart rate increases, when the rate of generation of impulse increases, more and more impulses pass very quickly through this extra bundle, okay, and the ventricles start beating very rapidly. They are not filled properly, but they keep on beating, and this may lead to ventricular fibrillations, right? Fibrillation means increased beating of ventricles. The ventricle beating rate or the heart rate may reach up to 300 or 400 beats per minute, right? So that is one very dangerous complication of Wolff-Parkinson-White syndrome, and this extra bundle or this extra connection is known as the bundle of Kent, Kent. It is known as the bundle of Kent. Okay, so this is all about the Wolff-Parkinson-White syndrome. Now there is a second clinical condition that also has a fancy name, but it is also really very simple, and the name is Stokes. Let me get this out. Okay, Stokes-Adams syndrome. It is known as Stokes-Adams syndrome. Now what happens here? Here there is no extra connection. No, this extra connection is for Wolff-Parkinson-White. Here what happens, the anatomy and the connections are normal, but there is a problem in the AV node. The AV node is blocked. There is sudden blockage of the AV node. Now we know that AV node is the only channel normally which conducts the impulse. So if the AV node is blocked, there is no impulse reaching the ventricles. So what will happen? The ventricles will not contract. If the ventricles do not contract, they do not pump the blood. If the blood is not pumped, there is no blood to the brain, the person faints, the person loses consciousness, right? So what happens here is that when the AV node is blocked and when there is decreased blood to the brain and when the person faints, the Purkinje fibers, they start making a rhythm. Remember, like I said, the entire conducting system of the heart is capable of generating a rhythm, is capable of autorhythmicity. Since the Purkinjes have realized that the AV node has been blocked, they have to generate their own impulse for the ventricles to keep contracting, to keep beating, so that they keep on supplying the blood to the vital organs, including the brain. So what happens is that when there is sudden blockage, the ventricles fail to contract. Now, before the Purkinje fibers take over the contracting or the pacemaker functions, there is a delay of 4 to 5 seconds. The Purkinje fibers need 4 to 5 seconds to understand what is happening, that the AV node has been blocked and they need to start the pacemaker activity. And in these 4 to 5 seconds, the brain does not receive any blood because the ventricles are not contracting. So the person faints, right? So after about 4 to 5 seconds, what happens is that ventricles start beating and the ventricles generate the rhythm at the rate of 15 to 40 beats per minute. 15 to 40 beats per minute. And this delayed pickup of the Purkinje fibers, the 4 to 5 second delay that is there, this delayed pickup resulting in unconsciousness is known as Stokes-Adams syndrome, right? So what is Stokes-Adams syndrome? Stokes-Adams syndrome is the delayed pickup of the Purkinje fibers because of sudden blockage of the AV node. The person may faint in the Stokes-Adams syndrome, right? So these are two clinical conditions, the Wolff-Parkinson-White syndrome where there is an extra bundle of Kent, and the Stokes-Adams syndrome in which there is a sudden AV block. So guys, this is all about the origin and spread of cardiac impulse. I hope it made sense. I hope you understand everything that I have said, and if you go back to your books and you read it once, you'll get it very clearly in your heads and you won't ever forget it. That's what I hope. So that's all for today, and I'll see you in the next one.